నార్మల్గా యూట్యూబ్లో చూడాలంటే ఎట్లా? పెట్టేసిన అయితే సార్ ఓకే మ్యూట్ పెట్టి నాది ఈ వీడియో కూడా ఇది కూడా మ్యూట్ అయిద్దేమో నాది
అర్థం కాదు.
ఇది నేను మాట్లాడేది కూడా మ్యూట్ అవుతుందమ్మా. యూట్యూబ్ మ్యూట్ పెడితే యూట్యూబ్ మ్యూట్, ఈ మ్యూట్ వేరేగా.
యూట్యూబ్ మ్యూట్ వేరు, మీరు జూమ్ లో ఉన్న మ్యూట్ వేరు.
అది నువ్వు యూట్యూబ్ మ్యూట్ పెట్టినావా?
యూట్యూబ్ మ్యూట్ పెట్టేసిన కాబట్టి సో మీ సౌండ్ మీకే మళ్ళీ రీసౌండ్ రాదు.
ఓకే సరే,
మీరు లైవ్ ఉంది ఇప్పుడైతే.
ఓకే. Webinar. Okay. Hello. Yeah, I'm just opening. You can open, madam. You can just check. Good morning, Dr. Ramana. Good evening. It is also.
Sir.
Yeah.
Is the voice clear to me?
Your voice is clear. How about my voice?
మీది కొంచెం తక్కువ ఉంది.
వాల్యూమ్ తక్కువ ఉందా? ఓకే.
మీరు కొంచెం ఇయర్ ఫోన్స్ కి వెళ్ళిపోవాలా మీరు.
So it is also being relayed on the YouTube.
Oh, very good.
Live on YouTube.
Are there any special group of participants like critical care specialists or?
I have invited some of the critical care specialists, madams, students, people who are there now working as a critical care specialist. All those invited, but I'm not sure how many of them will attend.
బ్యాక్గ్రౌండ్ చేంజ్ చేసినట్టున్నా మీరు, అదేనా?
The same background. I don't know. I think Manimala madam has not yet joined.
ఏమైనా రిమైండ్ చేస్తారా మరి ఒకసారి?
No, I just know she called and she told that she is joining.
Are you having access to my slide also?
Yeah. Shall I focus it now or?
No, then not. అది మనం మినిమైజ్ చేసుకోవచ్చు ఇప్పుడు. మీరు ఇప్పుడు ఏం అవసరం లేదు అది.
How is the background, Dr. Ramana? Is it visible?
Yeah, very much visible with all the three logos and live on tube and kuda vastundi.
That is GVK EMRA HO EMLC is the Anand and other people also about this slide.
Additional sounds వస్తున్నాయి.
This sound is, I don't know from where the sound is.
అది
It's
యూట్యూబ్
not
సౌండ్
from
కాదు కదా.
నా దాంట్లోకైనా వస్తలేదు. I don't know. Shall I mute it all? I think from some participants it was. Now it is not there. Dr. Ramana, you can unmute yourself.
Yes.
Okay. మేడం ఇంకా ఎంటర్ కానట్టుంది.
అంటే ఆమె పేరు మీదే ఉందా లేకపోతే ఆన్ బిహాఫ్ ఆఫ్ హర్ we are seeing
That's
other
what I'm
names
saying.
also.
సార్ జీవికి ఎంఆర్ఐ హెచ్ఓఎంఎల్సి రాజా సారే ఉన్నాడు సార్ ఇక్కడ హోస్ట్ గా ఇప్పుడు.
అవును కదా, అవును. ఓకే.
Even Anand,
సార్
it is coming on the YouTube. Same GVK EMRL
హెచ్ఓఎంఎల్సి సార్.
HOMLs.
మనము ఎండ్ టైమ్ ఏదైనా ఒకసారి you need to think about it, Dr. Rajanarasimha.
Yeah, I told it will be 8 o'clock.
8 o'clock.
Madam has come. Good evening, madam. You can unmute yourself, madam. Yeah.
Madam, good evening to you.
Good
Dr.
evening.
Ramarao here.
Yeah, I know. Ragnar. How are you? Good to see you.
Thank you, madam. Namaste to you.
Nice, madam. We are in time and we'll start exactly at 7. So this will be for 1 hour.
Okay.
Half an hour of this presentation and half an hour of discussion.
Yeah.
So this is also being played live on YouTube.
Okay.
So many of the participants they may be coming on.
Yeah.
Madam's voice audible, madam? మీరు ఒకసారి
Yeah. Can you hear me?
Yes.
Yeah.
Yeah, clear and loud.
There is
Clear.
no problem.
Yes, very good. Your slides will be shared by Dr. Rajanarasimha Rao, or else you will be running the slides.
No, I have sent it to him because he said I can't run the slide.
Okay, then right. Good then.
Okay. I'll only just say next, then you can go for the next slide. That way.
Dr. Rajanarasimha Rao.
Yeah.
Madam has already sent you the slides.
Yeah,
You would be
she
the
has
one
sent the
who would be-
slides.
Okay.
So just shall we start or shall we wait for some more time?
It's up to you. I am ready.
Just one more minute, madam.
Yeah, give it 1 or 2 minutes, our Indian standard, no?
I see many of your
Students?
are attending this,
Yeah.
madam.
But they wanted me to send it, so I sent it to a few people
Oh, thank you.
because I have a large following. You know that. Though I am pretty old now. Need the fan. So, how are you all doing?
Madam?
Ramna Rao garu, meer ela
Yeah, we are fine, madam. For today's webinar, we came to our house. Otherwise, we would have been on the road around this time. We thought we would reach home early and then be a part of this webinar without any disturbance and in a very focused manner.
Have the things have increased again now? The pandemic.
Yes.
COVID patient, yeah. Slowly.
Again increasing. That's what all my students are telling me, that the number of cases have gone up again. So,
but still
it's not that bad. No?
The mortality rate is not that high.
Because now we know what to do a little earlier. People are doing things. So maybe the mortality is. Maybe we have a little better immunity because we are not that clean as Westerners. No? We have more things here. So maybe that is the reason also. We have more immunity.
Dr. Rajendra Singh,
are you able to see the slide, Dr. Ramana?
Yes.
Where I can't.
So
you need to use enable edit mode and then full screen at that time.
Yeah.
Okay.
Enable edit on the top yellow line. Yes. You can minimize that.
Are you able to see?
I have to do that.
Yes.
Do I have to do that? What should I do?
No,
no,
madam, not now. So, good evening to one and all. We are very privileged and honored to have Dr. Manimala madam today to talk on this very controversial topic, which we have requested her to talk on this. And before the session starts, I request our director, G.V. Ramana Rao, to give a welcome message and welcome madam to this webinar. Dr. Ramana.
So good evening to all of you. Thank you for joining a very special webinar. In fact, GVK EMRA has been running this series of webinars, and after completing some of the fundamental things, we are coming into some areas which are of very key importance in terms of the patient outcomes. Today, we are very, very fortunate to have the guru of the gurus in anesthesiology critical care in this part of the world, to my knowledge, no other than Madam Manimala Rao Garu. It is a great honor for us to host her as a speaker for this. And when I met her some time back, I was asking her that you are all considered, she's considered as a Bhishma in terms of this discipline of medicine, and then she was very fondly saying that there should be a female gender for that name. Nevertheless, there are many people, many next and third and fourth generation of anesthesiology critical care. They're not only the torchbearers of the cause with which she has dedicated maximum years of our professional life into this area, but it has brought a lot of glory to the discipline of anesthesiology and critical care. Now that several changes have come up in the COVID pandemic, it is known to many of us that people on ventilators will have high mortality rate. And no other than Dr. Manimala Rao Garu, I think she is the one who would be able to bring all those very finite views and a very, very special lens of 3, 4, 5 decades of her expertise in this. Before we go into the nuances of today's discussion on the ventilator and COVID and the high proportion of deaths, I just wanted to share with you what is the current scenario here. India contributes to about 2.9%, which comes to about 1:38. For every 38 cases, India is contributing to 1, but in terms of deaths, it is very close to 10% at the global level. After US, we have got the, I would say, the dubious distinction of bad in terms of outcomes of the patients and the number of cases. If I look into the doubling time in cases and the deaths, it is definitely better, 139, 140 days of doubling time in terms of cases, but the deaths is about 184. This is what India is faring in terms of the global pandemic of COVID-19. But the current scenario, we are having about 93% people who are all affected with COVID. They are coming to about 95 lakhs, though I mentioned 85 lakhs. This is from the Government of India's official. But across the globe, we are almost touching 1 crore. We are almost touching that magic figure of 1 crore. But fortunately, India is having a current case fatality rates of about 1.46, which is very good looking into the healthcare system in our country. The active cases are at present about 4.5. Having said that, India has really developed a very large network of carrying out the lab tests, and it is hovering around 10 lakhs or 1 million every day. Having said that, from the state from where we are now conducting this webinar, the Telangana state, there are about 11,500 active cases. Cumulatively, we have about 2.5 lakhs, and then the deaths are around 1,500. I want to just touch base on a new aspect which is coming up as a very interesting in the entire life cycle of the pandemic in the form of a vaccine. Very recently, Honorable Prime Minister has conducted a very important meeting with all the state heads on the logistics of the vaccine in case it is made available in the country. So this is a very important preparedness from the nation's point of view, because I have not seen such a preparedness meeting by the head of the country on this. I also want to hurry to add that in Hyderabad, in the Medchal area, we have this Bharat Biotech, and then along with ICMR, there is a vaccine which is named as Covaxin. It is in the 3rd phase, and a randomized double-blind control trial is on, and it's multi-centric also. And I'm sure that when the outcome of this phase is out in favor of this vaccine, I'm sure that there'll be a lot of such celebrations. And 7 out of 10 vaccines are produced from Hyderabad. And even in COVID also, we are expecting the same thing. Yesterday, Bill Gates was also referring to the role of India in that. I just wanted to quote the statement made by the Serum Institute of India's head. He said that it's an expertise with all the dynamics of vaccine availability and then reaching the last mile. They mentioned that by 2024, all Indians will be vaccinated. So that is a very optimistic scenario, but it's very important that we move every day and every month and every year also. At this organization, GBK EMRI, we are extensively involved in all facets of the COVID endemic. It's not only transportation. We are involved in telemedicine. We are involved in home isolation. We are working at the community level in terms of taking the samples for the labs also. Cumulatively, we have transferred about 13 lakh cases across the 40 states and two states, which are all centrally administrated. And in Telangana, we have about 54,000 cases. Unfortunately, we have lost 5 of our associates we are now declaring them as COVID warriors. So we are also part of the frontline workers. So we are very, very keen that today's session should throw us more insights into specialized perspectives of Dr. Manimala Rao. So I will stop here and I'll thank once again for joining the webinar today. Dr. Rajana Singh, if you want to introduce her formally, I will now hand over the mic to you, Raja. Thank you.
Thank you, Dr. Ramnath. Thank you, Madam, once again. And nobody needs Dr. Manimala Rao's Madam's introduction, because most of them, the ICU management, the anesthetic management, the emergency medicine management, the everything in anesthesia was taught by Madam to each and every individual who are there now working in the ICU. But let me brief her about her education. She did her medical MBBS from Usmania Medical College in '66, and she has completed her DA in London, UK in '68, and she worked in, she has her MD from All India Institute of Medical Sciences in '72. And she was this madam, I didn't know that you have also worked in Iran. She was a consultant in Iran as anesthesiology from 75 to 79. After returning from Iran, she joined as assistant professor in Gandhi Medical College from 79 to 86. After 7 years of her services in the government hospital, she joined NIMS as an associate professor. From 86 to 87, she was an associate professor, and she became the professor and head of the department in the NIMS from 1987 to 2004. And during this period, in 96 to 99, she was the medical superintendent of NIMS. So this is a brief thing what I wanted. In her, as a professor and head of the department in NIMS, she has presented a lot of papers, lot of presentation, lot of research work was done. I'm also very fortunate to be a student of Dr. Manimala Madam for 6 months in cardiac anesthesia. She worked intensively, and she's a pioneer in cardiac anesthesia. She has started cardiac anesthesia in NIMS and I should say throughout the country. The good thing about Madam was she taught each and every anesthetist that you are not just a person who anesthetize a patient. You have to take care of the medical ICU. You have to take care of the RICU, respiratory intensive care unit. You have to take care of the surgical intensive care unit. You have to take care of the emergency medicine department. You have to also take care of the pain management. So this was the thing she implemented to all her anesthesia students, and now everybody has followed it. And now I think everywhere, many of the students are placed in a very high position, and most of the intensivists are the critical care specialists who are working as the heads in different hospitals in the city of Hyderabad and other cities are students of Madam. And another interesting thing is, even Manimala Madam not only has done all these things for the anesthetist, even in the emergency medical care in our EMS system, she has trained the EMTs about how to manage the emergency medicine people. And also she has also prepared many of the protocols which are very still followed. Whatever protocol she has put, she's still followed by our EMS 108 service system. We have requested Madam to talk on high death rates in this COVID-19 patients who land up in ventilatory management. Apart from this, Madam, I request you also to have a little bit of presentation about the second wave, which is coming over in our country and throughout the world. And I will be very happy if you can talk a little about the vaccines which are coming to India and throughout the world. And yesterday I've seen even our CM of Telangana was telling that the vaccines has to be given first to the healthcare providers who are working as a healthcare. So these are the things which we want to listen from you, Madam, about, because you have a lot of experience in critical care patients right from the beginning of your practice as an anesthetist. Madam, over to you. I think I'm able to, are you able to see your slide, madam?
Yeah, I can see very nicely. Yeah, you can go to the next one.
Yeah.
or the first one, if you can go, just the first slide, back.
कल गया था
Or you go to next one, doesn't really matter. Yeah. Very good evening to all of you. And it's very nice that Ramna Rao Garu and Raja Narsingh Rao have asked me to talk to you all about this pandemic. Though I haven't worked in it because of my age, I was not allowed to. I would have loved to do it. But I have been talking to all my students. Most of them are, as you said, that they are heading the departments now. So my first one would be, there are many questions. Are there any complete and correct answers till now? Some yes, some no. How much do we really know about the virus? Something we know, but we are learning every day. And what is the physiological background? So unless we know all these things, it is a little difficult for us to do it. Next. As soon as I finish, go to the next. Next slide. No. Yeah. Next. Yeah. So what is this virus really? It's a simple RNA strand with a spike and an envelope. So the spike, it will push its way through and then envelopes the cell. That is how it works. And it's a respiratory virus, like the SARS virus, coronavirus. It's a respiratory virus. So it enters through the respiratory tract, upper, and then it goes. Very contagious, like the Spanish flu. We all were not there, but it was, Spanish flu was very, very tough in those days when things were not up to the mark, the healthcare. And it has got a very unpredictable spread. And we have asymptomatic spread. So that is why this is also has got a very high mortality in the elderly with lot of comorbids and those who have got immunocompromised. So it has come from China markets, similar to coronaviruses in the bat, and it has affected almost all the countries in the world. And it is a clueless spreading, really. We just don't know the clue. Is it spreading? How? Test, sometimes they give you a variable result. I have known quite a few of my people who had this coronavirus. They had definitely the CT, RAD 4 and 5, but the tests were negative. I said, no, go to the hospital, get the treatment. So it improved them after that. So the tests sometimes are variable and it's a totally new entity and we are all learning by trial and error. We are all the time reading and trying to learn. So next one. Now, why does it affect the lungs? This is what you wanted me to speak because I have a lot of experience. I had done a lot of research into ARDS. So it causes ARDS. So that's why does it affect the lungs? It is a respiratory virus. It affects the upper and lower respiratory tract, but it can spread everywhere. Now we have it in the stool, in the urine, in the fovite form, in the airborne, everything. Now everything is now coming to the fore. So if you want to know why does it affect the lungs, we have to understand the physiology first. How does it affect? Why does the lung have got an affinity? And what is it affecting the primary function of the lung? So now let us go back to the base of why it affects the lung. Now first we have to understand renin-angiotensin and aldosterone system, the RAS. Okay. So whenever you have a inflammation, injury, or a disease, what happens is if there is inflammation, there is always the bradykinin gets secreted. It causes vasodilatation and there will be a little bit loosening of the walls between the cells, cell wall. Between the cell walls, there will be a little bit of, porous. So what happens is when there is a little hypotension, then the liver secretes angiotensinogen. This angiotensinogen goes to in the kidney, it is converted to angiotensin by secretion of renin. So the renin is secreted once liver secretes angiotensinogen, and this renin makes it into angiotensin 1. This angiotensin 1 is usually carried to the lung. The lung has got what are called, the ACE enzyme, that is the angiotensin converting enzyme. So this is in the cells of the lung. So this converts into angiotensin 2 in the lung, and that is released to the bloodstream, and that it will cause vasoconstriction. So there is always a mechanism by when you have inflammation, the body will take, when there is injury, inflammation comes. And when the inflammation is getting more, the compensatory mechanisms are these, they come in and then cause a little bit of vasoconstriction. Sometimes the aldosterone mechanism, it will get more fluid into the, it retains fluid, so you have more to pump. So this is what is the normal mechanism. Next. So the virus enters these angiotensin converting enzyme and does not allow to counteract the inflammation. So this is what happens. So it prevents the counteraction of the inflammation. So it is more, this enzyme is more in men than in women. So that is why we see little higher mortality in men as compared to women. And the severity and mortality is more in the male sex. And when the cytokine storm becomes unparalleled, that is, this angiotensin 2 is not coming to counteract it, these macrophages which are there, and anything, if you see, even if you see the valley or villi, which you have ventilator associated injury, what they have seen in the earlier days is when they have did the cut sections of people who died on ventilator, they found that all the macrophages are near the alveoli. This is what happens. So they come and invade the alveoli. The alveolar membrane breaks and then breaks down, and then exchange of gases becomes difficult. So this is the base for exchange. Next. So next one is you go to hemoglobin. We know that hemoglobin is got a 4-pyrrole ring and it has got a ferrous ion, and this is what takes the oxygen. So that is the structure of the hemoglobin, what you are seeing on both the sides. It's more in the red cell, and this is the diagrammatic representation. So what has this done? It's a porphyrin bound to iron and globin, so it is called hemoglobin. That red spots on that are the iron which will bound to the oxygen. So when you have it in the lung, the hemoglobin takes up oxygen. It is divalent form. And when it goes to, and then gives off carbon dioxide, because it not only carries oxygen, it also carries carbon dioxide. It has got a different methodology how it carries. So when this goes to the tissues, it becomes the other way around. It gives up oxygen. It gets it is reduced hemoglobin or trivalent. So this is how the hemoglobin carries. I mean, this basic. So if we understand this basic, it's very easy to understand what is the pandemic causing. Now we call it happy hypoxia. In the beginning, this virus affects the beta chains in the hemoglobin. Okay. So it does not allow it to carry oxygen from lungs to tissues. So that is where it is putting a break. So they do not have breathlessness at that time. So that is why you call it happy hypoxia. But they do have hypoxia. Now we can give oxygen, so that because the hemoglobin is not carrying, plasma also carries. So when plasma carries, if you give higher percentage, plasma will carry. If you give 100%, instead of carrying 0.3 ml per 100 ml, it will carry 2.3 ml. So you can do something. That is why we think about hyperbaric oxygen in such. So rebreathing mask and HFNC will help at this happy hypoxia. We have to do it. We know that. So the other important aspect we have to understand is hyaluron theory, that you know that there is what is called the hyaluronic acid, which is there everywhere in the body as a cartilage. It will nicely make a matrix. If there is inflammation, this particular hyaluronic acid, or it's now called hyaluron or hyaluronan, you can call it anyway, it is present in the extracellular matrix. These levels of this get very much elevated in the inflammation because it wants to go and make it become better matrix. So the molecular weight also varies from 4 to some 200 or something like that. And in healthy condition the molecular weight is lower, and in inflammation the molecular weight is very high. So when the molecular weight, depending upon the molecular weight, it absorbs 1,000 times of its molecular weight and forms like a gel. Then suppose in this time, suppose if you give some inhalation of hyaluronidase, preventing too much of this hyaluron, forming a gel. So this side you have got a normal lung where you can nicely make out all the the alveoli, the septa, and proper lung. But whereas on this side, you see the gel-like substance with the arrow there. It is just filling up the alveoli. Okay. When it fills up the alveoli, naturally, suppose if you have got pulmonary edema, what happens? Water fills up because there is too much. So when it fills up, you cannot exchange the gases. So that is what happens. Normally, the alveolar epithelium and the vascular endothelium have got only 1 micron thickness. Okay. If it becomes more, naturally, it will be this gelatin type of thing will form. So the other thing, the last thing, which we all know now, is the coagulation and pulmonary embolism in COVID. Why does it occur? You know that tissue has got methods of procoagulants and anticoagulants, and they always have a nice, sort of a, they have a good, both of them gel well, and they do not have a problem. But this pandemic, what you are seeing is this sort of a good attributes for procoagulants, anticoagulants is lost. There is more and more of fibrin clots, and there is more of that fibrin clots are blocking everywhere in the vessels, including the alveoli. So what they call next. So well, I think this has come. So what is the microthrombi? How are they caused in the COVID? Almost 7 to 39% of mechanically ventilated patients at peak. And the normal D-dimers sometimes help you, maybe is not still having. It could be give you some sort of an idea. But the imbalance between the pro and anticoagulation due to severe cytokine storm is what is happening. This disturbs the bronchoalveolar hemostasis. And hypoxia also increases the blood viscosity. Okay. The hematologists, some of them I have read, they have said that they have never seen such a sticky blood in any time before this pandemic. That is the pathologist, hematopathologist. The dysregulation leads to intraalveolar clots. Again, that will cause a problem for exchange. Okay. So what exactly is repair process in ARDS? So you have all these which are happening. What happens to repair? Any organ, when there is an inflammation, it heals by angiogenesis, some amount of collagen formation. It comes back, it wants to comes back to its normal thing. So the fibroblasts rush in and finally form the matrix. But if the damage is severe, if the the gel formation is a lot, there will be too much fibroblasts entering, and angiogenesis try to occur much faster, like in this particular pandemic we are seeing. So fibrosis becomes faster in these patients. So in COVID ARDS, this gel-like substance and early fibroblast repair is leading to severe fibrosis, and that is also leading to problem to ventilate them one. And problem in the post-COVID area, COVID time, they are getting more breathless and they're continuing to have hypoxia, and sometimes like when you have patients with interstitial fibrosis. That's what. Now, why mechanical ventilation is not helping as it should? Now, here I would like to just say, in the ARDS, what you call it as a baby lung, you all know, baby lung means the amount of normal lung present is small. So, there will be some amount of recruitable lung. So, by using your mechanical ventilation, you are trying to take up the recruitable lung, which is somewhat in the middle. Other one is the fibrous lung. If you try to recruit it, it will not get recruited, but it can, burst and also give you a problem of a pneumothorax. So we have to use the ventilatory lung protective strategy. And I am one person who has done a lot of studies on this ARDS. And I found that the pressure control ventilation with low tidal volumes, that means you are using the driving pressure to be around 14, 15. So if you use a volume control, and even if you put this thing, if the pressures tend to rise, this is what I've seen. And I've used my pressure control for a long time, and most of my students have learned that. And pressure control, what you are trying to do is you are controlling the pressure and you are only giving that 6 ml, whatever is the tidal volume. Okay. So this will help a little bit of recruiting the alveoli in a little better way, not increasing the driving pressure, trying to keep. So driving pressure is the peak or plateau minus the PEEP. And we use higher PEEP in ARDS. So this is what. And then you can even put awake prone, which many people have done, found it useful because the lungs come, upside down. So they are better ventilated, and prone position has shown that. And I've used prone position for regular ARDS and found it to be very useful. You can recruit with this lung. But in here, you don't have to go to inverse ratio, but you can manage without that. But pneumothoraxes are also surgical emphysema, bronchopleural fistula have also become fairly common in these patients because of early healing, fibrosis, too much of collagen, no gases exchange, and so on and so forth. So the mortality in influenza is about 0.1 to 0.5, whereas in COVID, it's about 3 to 4, or been more in many other countries. And I'm very happy he showed you all the statistics of our own country and the state. And elderly with severe comorbidities, it is higher. And severe disease on mechanical ventilation is also high. And they have found that if you have come very late to a ICU, that is you're burnt out, that is you've gone to another hospital, and from there almost at the end you came and we ventilated. These are the problems which you will face in patients who have got high Apache scores, and it's almost 60 to 75%. That is why we are not able to. In ventilated patients, when they go, the number of days, more than a week, is also going to go to high mortality. One, severe cytokine storm. In the beginning itself, they are going into multi-organ. Second is this, when it is continuous for about 6-7 days, because they don't want to do early tracks, these are ending up with a secondary infection, which is pretty common, and we have got very bad infection rates because we use antibiotic irresponsibly. Okay, so next. So for oxygenation, you all know nasal prongs, don't use more than 3 to 4 liters because it won't help. It will only cause more injury to the nasal nose. Pre-breathing mask, about 8 to 10 liters or up to 12 liters. HFNC is one thing where you can use it in happy hypoxia, but don't keep on using it if the patient has got breathlessness. If there is breathlessness, you should go to a BiPAP with a higher pressure. Try. But if there is nothing you can do and still you are having a problem, then it's the mechanical ventilation strategy with lung protection. Then prone, awake, and mechanical ventilation, they both can be done. And people have gone to ECMO and also hyperbaric oxygen. We have not tried, but people have tried, and that could be one of the things in the maybe in the early stages. Next, next. Yeah. So you asked me to just, this is all about why we have a problem in mechanical. I hope I made it very simple so that everybody can understand, and you can read more about it. It's a new virus. We don't know much. Caseload is still there. It is high. Herd immunity is not possible. It's not a possibility. Specific treatment modalities are still evading us. Of course, we have uh, dexamethasone and remdesivir. Remdesivir proved to be a fairly good one, 5 days to 10 days, whatever is the thing. But I think it is working. At least it should be given a little early, not wait till the end. Lockdown is over. So in the lockdown, what did we do? At least we contained it for some time, and we prepared, as Ramna Rao said, that we are prepared for this. Otherwise, it would have been very tough in a resource limited country like ours. Virus is very clever. They're there for millions of years before us. So it is mutating fast. And guard is down now because people are having festivals, politics, elections, shops, all these things. Now, if you see many times, I'm sorry to say this, but people don't know how to wear the mask. People talk taking out the mask down. I mean, what is that you are wearing for? So these are things which we have to be very. The second wave is because of that. Now, next. So still eagerly awaited, but I think it is in the pipeline. There, it required a lot of studies, and it has to be tested on volunteers, and it has got so many phases, and it has to be given to healthy people. So there has to be least complication rates. So that is what they look up. Next one. So we have next one. Yeah. So now we have Oxford, AstraZeneca, Moderna, Sputnik, and so many things are there. Our own place, we are doing so many, things in Pune. So what is the cold chain? That is also another thing we have to think. How possible it is in a developed country? Some of them said minus 70. Is it possible? And what are the costs? I'm sure they're going to bring down the cost, at least in India, and how long the vaccine is going to work. These are our questions. The questions and answers will be coming. As we have earlier, we did not know anything about it. At one time, they said plasma therapy is the best. Then they said no. Then toxiclimab is very good. And then finally they said, okay, let us go to remdesivir and dexamethasone, ventilation, oxygen, all these things we have come to. Now we have understood more how is the virus spreading. So there are many questions, but I'm sure there will be light at the end of the tunnel. And the medical fraternity is working at extra space at all levels. All the people are working, and it's really heartening to see how many people are working, and including our IMS, technicians, so many people along with us, the nurses, the ward boys, so many of people, even in spite of getting them, they're coming back and again work. So kudos to them. Next slide. Okay, how can we control at this time and how can we prevent it? Wear mask properly. Now, if you see any politician, I sometimes feel like telling them, come on, man, wear the mask properly on your nose. Okay. Hand hygiene, and try not to touch the face, because normally we just touch the face number of times. So now I'm more, um, think about it. If my hand is going there, I think, okay, is it necessary? Something like that. It should come in us. Some amount of social distancing. Avoid crowds because it can wait. It's nothing. We have enjoyed life for a long time. For some time, we can be a little more careful. Wear gloves in public places. I think you should, because when you go touch your, wherever you go to the lift or you're holding on to some of the areas where you're standing, and have low key celebrations. And I'm sure awareness programs will do a lot if we can sort of make them and do the health education. And of course, we are all doing, like the IT industry, now we are doing this more online work. And people like me also, much older, I have learned how to be online and I take classes. I feel happy that I'm still able to do and be a good citizen. Democracy means responsibility with rights and free speech, but it does not forget your own responsibility and only ask for right. And stop blaming the government, somebody. What are we doing? If everybody keeps this in mind, we can fight it together. Next. Okay, these are some of the references, but there are a lot of material on this thing. Next.
The last slide.
Yeah, this is last slide. And no, last slide I want to say. Last slide. Okay, last. It's not staying. Yeah, I thank all the health workers, police, GHMC workers. They're all saving lives against all odds, against their own life. I really appreciate so much about their work. Be safe, but not sad. Be happy that we are getting to time to spend with family. And I thought I will be very lost if I'm not working, but I am very happy now. Not working, but I'm trying to do all these things. Okay. Thank you all for giving me this opportunity to talk. If there are any questions, I'll take it in the end.
Thank you very much, ma'am. So a wonderful brief presentation of what all the everybody had in their minds. I'm seeing many of your students
Yeah, I can see
participate,
Rambabu.
the names and all. Anyone want to ask questions, or you can put the question in the question box, or better you can uh, ask the question directly.
Or you can tell me what else extra you have seen.
This is one. There is a. Are you able to see the questions, madam? One
Where
question
are
is
the questions? Where are they? I can't see the question.
HFNC or helmet interface, which one is better? I didn't understand. To be frank, I didn't understand this question.
No, it's okay. I understand that question. Well, helmet interface, are you having it?
Yes,
They're
ma'am.
available with you, no?
Yes, ma'am.
Okay. So, if you are using that, how does the patient feel?
Better than the other modes of NIV.
So that is what. See, when see NIV is a little bit on a, it looks like a too much of a pressure that we all notice. After a little while, they feel, very difficult to keep it, and they keep on saying, take it off or do. So why the helmet thing came is because we want to make it much better, right? So that is what is this thing. But how much is the expense? Can you have it everywhere? Yeah, it is pretty expensive. And you have to understand how to work with it and how to do the nebulization, how to do all that. A better training has to be there. So otherwise, it is a better mode, no? We all know that.
Dr. Rambabu and all. Madam, one thing I wanted to ask now, the people are going for ventilation in this patient. Do you think they are prolonging, they are buying time to ventilate the patient, or they are going at the correct time to for controlled ventilation? Like they're
See,
giving.
I only tell one thing because when I have taught people at that time also, there is one dictum I used to tell. When you are in doubt, you ventilate. When you are in doubt, do not extubate. This used to be my way of teaching. But in this particular pandemic, what people have felt is that by putting them on ventilator, the mortality has, is higher. In all the ventilated cases, mortality is higher. But if you know how to ventilate, that is keeping the driving pressure low, keeping this in a pressure control ventilation, 6 ml tidal volume, if everybody follows maybe this, the ARDS can be managed. But then if you are keeping it for a long time on pressure, NIV, so what is that pressures you are giving? You almost go to 16 and 14, PEEP 14 and 16 or 18, up to that people are going now. So it is also very difficult for the patient to a higher pressure, and you have to give absolutely no leak. So if the leak is there, then whatever you are trying to do is gone. And third thing is, for having to do any nebulization and all that, that's also, of course, now they have got better nebulizers, you can put them, but all places won't have all that. But one thing, what I still feel is, if you have ventilated, can anybody tell me how long have you kept anyone the maximum number of days on an NIV? Can anybody tell me maximum number?
We have put
Madam,
for
almost 30 days, madam.
30 days. But then what was his PF ratios you have taken?
Every day it used to be less than 100 only, madam.
Yeah. But what about saturation?
Saturation max 88, 88 or 90s like that.
Then another question, two questions from me. What is about is any tachycardia?
There are always, madam, around 110 to 120. Always they are taking card. And
Okay. And what about the respiratory rate?
respiratory rate, same, madam. They are always 25 to 35 rate.
Okay,
Range I am telling, madam.
25 is okay. If the respiratory rate is about 35 and above, your NIV will be a little difficult for that guy. You may be lucky, you may come out, I'm not saying, but you have to keep a watch on all these things, not just tachycardia, respiratory rate, your SpO2, and how is the patient coping with it? Is he becoming very restless or is he becoming drowsy? So these are the times when you have to think of going to a ventilator. This is mine. Okay. I don't know. I have not sat with the patient, but usually this is what I would like. And I would like because I can ventilate these patients in the way I have managed them for all ARDS patients. And this may be a little difficult. I'm not saying you will have to give it for a longer time. As long as the patient is not become asthenic and he is becoming very restless or a little more drowsy, or the patient is not able to breathe at all and it's a 35 40, then you have to think. If it's continuing, if it's coming down, don't. In some days you may be having higher, but if you have gone up on the pressure and you are able to monitor, because monitoring is absolutely essential. So how much is able to monitor, because there's so many patients, so many of you may not be there with sitting with one patient each one. So how many nurses are there? It all depends. What is the thing?
Madam, one more question.
Hmm.
Actually, many of them, they have put it in this chat box about appreciating your presentation. It was very excellent. It was very simplest way of presentation. As usual, you have put it in the same way. One question, ma'am, from one of the senior analysts, HOD of this hospital. Diagnosis with ECMO, any good results, madam?
ECMO, some of them have come off, but as the ECMO, you have to have, there are two methods, no? Veno-venous and arteriovenous. These are two things. If the heart is involved, like, in the later time when you're going to, there are mods, the heart is also involved. Most of the organs are getting involved. If the more organs are involved, ECMO also is a problematic thing. So ECMO will be good if it is mainly the lung and the heart, if they can come out. Some people have come out. I'm sure in some of you would have seen an ECMO patient coming out, isn't it? Any of you have seen ECMO come out?
Yeah, there many patients have come out to some of
Yeah.
the
So that is
doctors
why,
also.
if you are, see, these are the things that I have put it in that. First oxygenation, then you go to HFNC, then you go to your pressure, NIV with a little higher pressures, and then you go to ventilation, with mechanical ventilation, with controlling properly, then you have to go take more. Then maybe hyperbaric oxygen, because people have tried that, but I don't know how much is the possibility. We don't have those sort of facilities in our
Madam,
place.
one question. What old age related changes are detrimental to patients' outcome in use of ventilator?
What old age?
Related
Get the question.
changes.
Somebody's child. What old age? What is that?
What old age related changes are detrimental to patient outcome in use of ventilator?
The regular, you mean to say?
Yeah,
Any
that
severe
is asked.
disease, any
Ramana Rao,
severe lung disease, any,
Rao,
sorry, anybody
Dr.
want?
Ramana Rao.
Yeah. Just because she has highlighted so many important aspects of the pathophysiology, I thought in elderly, the outcomes are more
Bad.
deleterious than the adults and the young people.
Yeah.
So is there any specific changes which are related to the age?
They usually say patients who are hypertensive and patients who are diabetics and for a cardiovascular disease and people who have got dialysis or a chronic kidney disease, patients who have got a lung disease, if there is any interstitial lung disease or a COPD. See, now you are seeing that even in Delhi with the pollution, the amount of severity of COVID is going up. So this is what is important. And as you age, all these organs, definitely they don't function well. If you are diabetic, if you are an older person, your immunity is less as compared to a younger person. That is one. Second, if you are a hypertensive, your arteries are like, bamboo. It is not like, they are not supple like the younger person. You're diabetic, by the time you're older, the diabetic affects almost all organs, including lungs. So, and even otherwise also, older people have got a higher mortality when they go on a ventilator for ARDS, regular ARDS, because they can get, their immunity is low, so they can always get more infections. And these are the problems which they have when you have an older person. And other one is also the Apache score. If they come with an Apache score more than 90, and Apache is acute physiological score with chronic health issues. So the chronic health issue also gets the scoring. So when you have that, in addition, in the younger you don't have. So nowadays you are finding very young people also sometimes are dying of COVID, which have quite severe hypertension or a diabetes. Or they get into pulmonary embolism because the cytokine storm is so much in there. Maybe we don't know why. Sometimes I feel some older person has come. I find it very difficult, but sometimes they come out with ARDS. But sometimes a younger person comes whom I think he will come out. Sometimes he may not come out. So these are the variables on either side of the spectrum. We can't 100% say. But on the whole, the older have low immunity, the older have pent up organs, the older have more comorbids. And this is the reason, and they come with a high Apache scores, and they delay also coming because they say, why go to the hospital? We'll try to, So they may not tell. Okay, these are all the things which, are the problems which you face. I don't know whether I answered your question.
Do you give any specific tips for paramedics on using ventilators during the transfer of the patient? Because we have our paramedics who transfer the patient from one
On ventilator.
on ventilator.
See, when you are transferring on ventilator, always you will be having a bag and, the connection, isn't it?
Yeah,
You
back
have got a vein circuit along with that. For that, you should have a separate oxygen cylinder, small one. Okay. I don't like the same cylinder. By the time you disconnect and connect it, you may lose time. The cylinder which is working for the ventilator again you have to disconnect and then use it. It will be long. So a smaller ventilator, a smaller oxygen for this particular thing for the paramedics is important, so that at least they can bag if there is a problem, if there is any battery goes, or if there is something they have not seen. They should always have a second this thing. Two, on the way, if they should be able to check the lungs. See, when sometimes when you transfer, there are two, three things. One, a bronchospasm can come while transferring. Patient may be on sedation, they would have stopped and then come in. By the time you start, there will be some, a little bit of time maybe there. Or sometimes while shifting, there could be a little, the tube will be shifting up and down. So it can cause a little more bronchospasm. So they should listen to the bronchospasm. They are good, no? They can listen to the lung. And also check what is the pressure. If the pressure is going up, then they should see whether it is any kink or is it any bronchospasm or is there any secretion. There are three things which you have to tell the people to look at.
Madam, this is just one question which I personally has.
Yeah.
In Western countries, what they are doing is when the patient comes to the emergency room, intubating, immediately they are putting LMS and then transferring to the ICU. Do you think that is a proper way? They're putting an LMS, laryngeal mask airways. They're not intubating and then transferring the patient before transfer the patient to ICU. Is it not that when you put an LMA, the aerosol generation may be more in that because LMA.
See, why do they do it? When you want to intubate hurriedly, you are much more exposed. When you have to do it in the emergency as soon as the patient are coming this thing. So when sometimes it could be a sudden cardiac arrest or something like that can happen. So that is why and then intubation in suppose obese patient, in a patient who has got a little airway problem. These are the problematic for us only. So it is much more for a paramedic. What they do is they are very well trained with LMA or iGel now, iGel. So iGel is much easier to place it. And as soon as we go, we can calmly do everything and then do the proper intubation for the COVID intubation. Because COVID intubation is little different, no? If you can do all that in the EMD, you can do it. But if you are worried about it, we don't have all those things. That is what they are doing. So I remember way back in 94, when I was talking in an Indo-American CME, they were saying that we have to have a difficult airway card. That time I told them for the obstetrics, that was an obstetric. I said, now you have to put an LMA in the obstetric health, the card. So it came, you see, you have to think much ahead of the problem. So these are things which people can ventilate, airway is secured, have a filter, okay? So this is what, and put a mask around or on that, okay, so that it doesn't go. So these are things which we can innovate. And I'm sure when you're doing also, now they say put a mask on that so that it doesn't come straight away to your face.
Good evening, madam.
Yeah, good evening.
Dr. Misra here, madam.
Where are you? I can't see you. Okay, it doesn't matter.
My videos are not on.
Yeah.
No, the simplest way you have presented, madam, as usual. I think you have narrated everything, you have touched everything.
Yeah, I tried my level best so that you won't think I am very old.
No, madam, nobody can think like that. We are all your students only.
Okay. Anyway.
A few things just to add, madam. Actually,
please.
I think the two most common thing what we see as a comorbid, one is diabetes, second is obesity, madam.
Obesity, yes. Obesity is another important.
Even young people who are having severe disease, going on to ventilator and all, most of them are obese and diabetic. They somehow, even in young people also, they have a higher mortality.
Yeah, definitely.
And if there are two parameters which is significantly shows some higher mortality, one is D dimer and second very high CRP. So we have consistently seen if somebody's D dimer is too high, let's say more than 5,000, 7,000, 10,000, and CRP is more than 200, 300 like that, those people somehow they don't do well. Maybe the cytokine storm is
Storm
very
is very high,
good.
in spite of your dexamethasone and steroid and remdesivir. See, that
Even
is what
after
I'm
giving it,
saying. That is what I'm saying. So each individual patient is little different. Okay, we get a randomized control trial. Even if you ask me, in ARDSNet trial, when we have seen it first, 6 ml tidal volume and 12 ml tidal volume. Okay, in 6 ml tidal volume, they control the plateau pressure. In 12 ml tidal volume, they did not control. And we never give 12 ml, right? We never give, even in anesthesia, 8 to 10. So what I am trying to say, there will be both sides in this spectrum. Something will be there. Obese people, everywhere they are difficult. And now obesity and diabetes is going in hand with the younger people because they are not moving, they are eating junk food, and they are having stress. So these are the three things which are causing the obesity. So this is what I feel that you should propagate now. When they try to get junk food to the ICU, I used to say no, no pizza, no this thing, so no burger. So they never used to like me for that, but I I always insisted, let us all bring from something from home. We used to make people cook and bring home, all the women. Okay, so and the men used to get it from some hotel. So that is fine. We can do that. Okay, because we are eating too much. So obesity, as he has said, I've also put it in my one of the slides, is the bugbear for this disease. And it is also difficult to intubate. It is also very difficult to put them on BiPAP because there is always a leak.
Actually, what Dr. Mishra said, I also rightly accept, madam. I put it as one the comorbidity. The first one is the obesity because we are seeing most of the patients who are younger, who are very obese. They are popping off very fast. Madam, there is one question from Dr. Snigdha.
Where is she?
Is non-invasive ventilation has any is non-invasive ventilation outcome any difference from non-COVID ARDS?
Non-invasive ventilation, is it different from?
Non-COVID ARDS patients. Non-invasive ventilation in COVID, is there any difference?
Now COVID ARDS again depends on, is it mild, moderate or severe. When you go to non-invasive, at least it is moderate. So it depending upon how much fibrosis has occurred, how much lung involvement is there. So then you can say about it. See, in ARDS itself, if you all, Sringda, if you remember, in your time, the ARDS mortality in all the things was about almost 50%. But then it has come down to around 25 to 35% in good centers. So I always used to take pride. Mine used to be quite less because I was very much after the ARDS means I will sit with the patient. I'll make one of my students sit with the patient and wean. Okay. So you know about that. You have worked with me and I hope you are doing well in Abu Dhabi, right? Okay. So this is all, we have to definitely, we don't know. There are still some more, they say non-invasive is much better if you can get away. And non-invasive will be okay, as I already said, if the patient is not tired or, respiratory distress is there too much. Okay, happy hypoxia, you can still go on. Okay, but if the rates are very high, if it is a 130 heart rate, 40, 45 is respiratory rate, can you manage that? In another few minutes, he may arrest. So we have to think between that and this. So at that particular moment, You have to see each patient for me is different. So I only take as a guideline. Okay. So this way we can always make it. Definitely your COVID has got more problems. And if they are obese, further problem. If they have a lung disease, is further problem. So non-invasive ventilation between COVID and this one, I have not really read. Maybe I have to just check it out.
Madam, one question from our EMS doctor, Dr. Anju. They get any suggestion for pregnant mother who is in labor and got COVID positive? Is that a high risk for the newborn as our EMTs has conducted delivery in 108 ambulance? Any advice you want to give for them?
What are you doing at the present? Tell me first. Because any question you ask me, I'll also counter question you. So in these, because that's how I learn. Okay,
Yeah.
questioning.
Actually, Dr. Ramanash has knowledge of what these people are doing in the ambulance. They are doing the deliveries with proper precautions, with all adequate precautions. They are doing it.
We have a disposable delivery kit right from the beginning, and then we have ensured that all our paramedic staff have the right kind of personal protection equipment, and we are also encouraging the patient attenders to be less and less during the COVID period. And we are also encouraging, if the condition of the patient in the patient compartment area is stable, the exposure to the paramedic should be lesser. So we are encouraging them to sit along with the driver. But in case of impending delivery, though we always say that ambulance is not the right place of choice because of the delay and the distances, we are still having several cases of COVID positive mothers reporting.
Delivered in the ambulance.
In the ambulance. So ambulance-based delivery, we are, so do no harm, and then our people are trained in basic life support and obstetrics, which also takes care of the neonatal resuscitation. So as far as the information is concerned, the mother to child transmission, right? It's not very high in terms of the COVID, and we have also the patient attenders and the pilot. So we stop the ambulance. We ensure that the delivery happens, but we are encouraging the third stage of the labor to happen in the institution or the hospital. Once we take this,
you try your best sometimes, but still you have people who deliver. You are doing whatever you can. I am sure the patient, the upper portion can be sort of screened out more. Means maybe you can sort of put a screen or something like that in the ambulance, which can be used, immediately. You can just have something like what we put when we have surgery. So like that, you have a screen and put some of these things. Give her a N95 mask with oxygen, whatever. Okay, and then put another mask on that. These are all things which you can help to
we are doing two things, madam. One is that, as you rightly mentioned, at least 6 feet distance, we are encouraging all the people who are all there with the ambulance patient attendants to wear a medical mask. We are not having N95 mask, one.
Okay.
Second, Raja was the one who has brought up this idea, and then we are encouraging them to use a plastic sheet transparent, so that the aerosol exposure will be reduced.
So it will be less. And after that, everything can be, disposed.
Yes.
And the sanitization of ambulance, anyway you do it. So
we are doing it very meticulously, madam.
And then you can see the newborn later on in the hospital, whether can be tested. That's all later can be taken care. You are taking most of it. If the screen is there, you are more safer. At least she is not coughing onto you. Or, because she's in labor, she will be doing, the pain is there. She will be bearing down. So those also can come, a lot of, things can come from her. This thing. So for her, you have to put those screen. That's what I also thought. I think it's a good idea. Yeah, Rambabu, you want to say something. You have to unmute yourself. Unmute. That's better.
Ramba.
Over you.
Can you
I
hear
see a lot of my students. Nice. Okay. You have again muted.
You have muted. Dr. Rambabu, you unmute yourself and
Then talk.
actually, Dr.
Yeah.
That morning I talked with Dr. Hashimi and she was Sharma and she was telling that, oh, today my
Ashima.
Hashima Sharma. I think she has joined. Dr. Hashima Sharma, you want to?
No, he is asking. Hello.
Good evening, ma'am. Good evening, ma'am.
Good
Morning, sir was saying about you, and I said that madam is the reason for my 1800 kilometers journey. I always treasure that. No matter that I've worked with you for a very small time, but the blessings and I know you have that immense this on me. I mean,
ask me a question. It's okay. I am fine. You can tell me personally.
I just lose my words whenever it is you. So I'm so sorry if I am just a little confused. But you know how much in my heart I always say that big ma'am is big ma'am. There is no doubt.
Thank you, Ashmi. Ramba, we want to say something.
But he's still on Rambabu. Now you can talk, Rambabu.
You talk. Now you
Madam, good evening. Can you hear me, madam?
Yeah.
Madam, I have one hypothetical, perhaps a little premature question. Are we going to have many respiratory cripples even after the whole thing is over, madam? Because the amount of oxygen we are using, the number of days we are using. I remember you telling us during our student days that the weaning starts from the time you intubate. So we are unfortunately not able to do. Like Bhopal, are we going to have many more cripples, madam? What is your gut feeling?
Well, my gut feeling is that nowadays I want to know how many patients are there with you on ventilators.
Not many.
Each one of you can tell me. Quite a few are there. So if you can tell, are there about 10 patients on ventilator in each hospital or more than that? Because I think it's a good idea. All of you put everything on online. Make one, EMRI. You can do this for us. You can make one this thing and collect the data. Then we can say very clearly. If I were to be there in any hospital, I would have done that. If you can collect all the data on ventilator and NIV patients in our whole of the city, we can do an excellent job. I'll help you out. I'll write the program for you. Okay? Nursing
Sure, madam.
Can we do that? So that we can tell, you just put the data. No name, nothing. So much age, you is so much, and ventilator, how many days, what is this thing? Post COVID, was there any problem? Okay.
I think many of the hospital ICU
yes, sir.
are there here.
Yeah, that's what I'm saying. If you can, I can help you all in this. I can do everyday survey on that.
Good evening, ma'am. If right at this junction.
Yeah. Who is calling? Baby Rani. Yeah. You
unmute yourself.
Unmute yourself. Unmute.
Yeah. So now that we were running our ICUs, nearly 3 ICUs, 3 zones with nearly 40 bedded in each ICU. We did have nearly 8 to 10 patients on mechanical ventilation.
No, but have you collected all the things? That's what
I can collect. I can. Yeah. I can collect because we are having the.
I can help all of you to come out and do a good paper. Okay. If you can take me with you, we can all do an excellent work by just having it online. We'll have a model and we'll put it in EMRI. Okay, so that we don't ask anybody anything. Okay.
And now that Rambabu sir was asking about respiratory cripples, already the queue has started in our institute.
Queue has started. Yes. I know a few people that they are. That's why I said this fibrosis happens so fast in this, particularly in coronavirus. I have seen a lot of ARDS because I want to tell you at this stage, I followed up my ARDS patients for almost a year and a half, some 30 of them. Okay. I wanted to write a paper on post ARDS PTSD. Okay. Post traumatic stress disorder. Because they say ARDS patients who are there in the ICU for a long time, all over the world, they say that there is a lot of stress and they don't do well. And so I followed up. I didn't find much. Okay, people went, they delivered, they had good children, and they had lovely life. They went to abroad, everything. Maybe because we have got a close family system, we don't just go away and stay by ourselves. Okay, so this is maybe I just said that this could be. So they have done. I almost done it for about a year and a half. So that way we have to follow up these patients. How many are coming? But this COVID, you have to say if those are on ventilator, they are coming back. Were they on only on
Oxygen
NIV
supports.
or only oxygen? We have to know. So kindly, Rajan Singh Rao,
Madam.
we'll send you one, this thing so that maybe we can ask everybody to
that is not
take
that
permission and then do this. You
Yeah.
write down now.
Sure.
So that you can, okay.
I'll write down and collect the data from all the
hospitals. Data from all hospitals.
The government and corporate hospitals.
Everywhere, it doesn't matter.
Sure. That is a good. That will be a good.
Let me do something for this COVID. Okay.
Yeah.
Take me in this research.
And one more question. Why?
Maybe you have muted yourself.
Unmute yourself, Rani.
Yes, sir. So, although we had so many COVID patients, obstetric patients, none of them went on ventilators except one patient who had peripartum cardiomyopathy. Any particular reason, ma'am?
Pregnancy, I don't have a good reason for that, but usually we do find that women, pregnant women, unless they have a obstetric problems, other problems don't touch them that much during.
Exactly. Even
and
COVID did not.
They're younger patients, and they have got, other hormones in them which are protecting.
Could be, ma'am, because only one patient went on ventilator. That too, she had peripartum cardiomyopathy. Yeah, none of them went on ventilator as such.
No, they don't. I don't know. That is what I have given the first cases.
Dr. Rani.
Yes, sir.
Actually, I collected this information. What you are telling, same with Fernandez Hospital and Rainbow Hospital, but exactly because they are also doing COVID patients, Rainbow Hospital, but they are also telling the same thing.
Yes.
That the pregnant patients are not, most of the pregnant patients are not landing up in ventilatory support. They're not becoming so bad as the other patients.
Non-gravity patients.
I think that data can also be collected.
Procured.
No. We should collect all data. Please.
Thank you very much, madam.
I'll help you to collect this data. I'll be
madam. Actually, madam told me.
Yeah, long time back you didn't come back. Okay.
So I thank one who have attended this webinar.
Hi, madam.
Hi.
Can I?
Namaste, nice to see so many of you.
Yeah.
I am honored today.
Amma. Amma, it's me.
Oh, Anu. Okay, yes. Where are you? You're not unmuted. My daughter wanted to listen. So I sent one link to her. So she's telling, Amma, it's me. Can't see her. Okay,
no, this is an amazing talk, Amma. I really enjoyed it. And it's lovely to see all your students from all over interacting. And I had a little suggestion.
You asked.
I had a little suggestion. Okay. So how about when you discharge the patients after COVID and all that stuff, get a baseline PFT. Just get a baseline PFT to include in this study. So when they are followed up, you can see how much restrictive, how much is obstructive lung disease, and then you can follow the PFTs as
that's
out
a good
in
idea.
pulmonology to see how they're doing for like 3 months,
Yeah.
6 months.
Okay.
Because like I can give you an example. One of my friends and colleague had COVID. She had remdesivir. Yeah, yes. Yeah. And her PFTs are showing restrictive lung disease at about 3 months.
More.
It's still there. It's improving a little bit, but it's taking time. Like, so I think definitely this is a great study. You'll actually have so many numbers because it's in India.
Numbers are more
Yeah.
for us.
Yeah.
That's why I'm telling. So Rani and Rambabu,
Yes, sir.
get on. Let us all meet again after about a week or 10 days. Let us see if we can. I'll get Narsingh Rao.
Yeah, sure, madam. After 10 days, we'll organize.
I will give you the protocol, how to collect the data. I'll put and write down. Okay, and we'll also put, as she has suggested, my daughter works in urgent care, so she takes care of a lot of COVID patients.
Thank you, madam. Thanks to your daughter who has participated in that.
She wanted to listen to her mother. Okay, thank you all.
Thank you, one and all. Dr. Ramana, can you brief us and close this session?
Closing remarks. Ramnagar.
Thank you so much, Dr. Manimana Rao. And I think you are still continuing to inspire many of your critical care anesthesiology students and many other professional colleagues like me. And today, I am also lucky to have a lot of paramedics right from Rajasthan to Karnataka to other parts of the country today participating in this. Though they are very special small numbers, but everybody has some take-home messages. I've been attending several of these COVID-related webinars for almost quite some time, but very few situations where such a simple clarity has emerged. Rather than dwelling from a top-down, you have come out with a bottom-up approach of using certain very basic physiological and pathophysiological mechanisms like the renin-angiotensin systems. You talked about hyaluron theory, and you talked about coagulation. Finally, you landed on the ARDS, where it is very evident that you had so much of control and many patients were benefited. And today also, whatever you have narrated out of your experience, I think there are a lot of application and implementation messages from you. Very nice to hear certain nice words like the baby lungs, the what I call, what I also heard about happy situations, hypoxias, right? So these things are very important, which have come out from an experienced critical care specialist who have been saving the patients. I think in this last 1 hour plus, I'm sure, like many of us have had a nice set of take-home messages. On behalf of all the participants here, let us give her a big hand by take out your mute position and then just clap, and then that is the best way we can do that. Please unmute yourselves and then clap for madam, right? That is a simple way we can honor her today. And then take care of you, madam. Be healthy, and then we will definitely meet, right? You are very inspiring today. Dr. Raja, as usual, you have been a fantastic moderator for all the things. Nice to see many old faces and good friends for several decades. Thank you so much.
Thank you all.
Thank you, ma'am. Thank you, ma'am.
Thank you, ma'am.
Bye-bye.
Thank you.
Leave now.
Bye, Rani.
Bye. Bye, ma'am. Nice to see you.